From a patient-centered design perspective, one of the major focuses I have is every patient should get triaged into something that is appropriate for them within 72 hours of voicing that they have a problem. And we've actually studied this. We lose 50% of patients to follow-up after that 72-hour window. So this is a real factor. And so when we know that it takes patients 30 days or more to get connected with an appointment, and then we blame the patient for not showing up, it's not the patient, it's the system. We failed that patient. Patient came in having done a bunch of work. There was a sense of urgency around needing to solve their problem, and we told them to wait. So that's what I think about when I think about collaborating with patients, is really trying to take the mindset of somebody who's coming into a system, having the courage to voice their challenges, and then creating a system that meets them where they are.
Welcome to another Meeting of the Minds with Wobot Health. I'm your host, Chris Hemphill, and we've partnered up with Going Digital Behavioral Health Tech to bring a lot of the conversations that are happening on the floor to you in a format that, hey, if you weren't able to make it to the conference or you wanted a little bit more, then you have the pleasure of watching it wherever you are. What we'll be going into today with Dr. Sam Nordberg here is precision behavioral health. Now, what is that? Well, what's the focus? We're going to get deeper into what precision behavioral health means, but some examples from a recent paper that Sam and his team published on PBH. There are over 300,000 different digital health applications out there, and these fall under many different categories such as wellness, therapy, prevention, provider interventions, things, and the like. But mileage varies between what these apps are for, which patients they're best suited for, and what symptomology they're best to present for, and of course the effectiveness of their approaches and interventions. In addition to that, we know that at least a lot of the digital teams and infrastructure teams that we talk to have hundreds of apps in the ecosystem that might be sitting on the shelf and collecting dust, not serving the patients that they need to be serving, but of course still draining the dollars from the system, while people who might need those interventions might go unheeded. So we see this a whole lot, Dr. Nordberg, and I'm just curious about an intro from you and just a little bit on your background.
Sure, yeah. So first, thank you for having me.
Mm-hmm.
This is great. So I'm a clinical psychologist by training. My first career was on Wall Street. Did a big about turn and got my PhD in clinical psych with a real focus on systems of care. And for the last sort of decade and a half, I've really been focused on how can we build systems that maximize our opportunity to treat patients in a way that gets them the most effective treatment as quickly as possible, keeps them engaged long enough to get that dose of treatment, so that we can enjoy getting that patient recovered.
So keep that perspective in mind as you listen. Keep in mind the idea of getting the right kind of treatment in the right dosage, but from this digital angle. I was really excited by reading that paper. Very new concept that we've been needing to address, and there's no better person to be speaking on this. Like, I'm sorry to pump you up too much, Sam, but currently serving as chief of behavioral health at Reliant Medical Group, but brings in a background. I thought this was a really unique background, that you have a background in finance, in clinical innovation, and in measurement-informed care, and that all kind of comes together. We're talking experience at Harvard Medical Group and Associates, Harvard Vanguard Medical and Associates, Mira Health. So I liked seeing the mixture of various careers, and also the focus in the tech world and also in the care delivery world.
Yeah, I think having those different backgrounds is really important, because the vectors of problems or challenges in mental health come from a clinical quality perspective, but also from a financial modeling perspective, also from a data collection perspective, and now from a machine learning and artificial intelligence perspective. And it's not anywhere on my CV or anything, but a long time ago, one of my undergrad majors was in computer science with artificial intelligence.
Oh, wow.
And so, I think I know enough to be dangerous. but not enough to actually do anything by myself.
Well, great. As we emerge from the AI winter, it seems that those kind of skills are going to come into being. But in all seriousness, no, though, it having that background in all those different groups that are traditionally siloed within the same organizations,
Yeah.
I think, and we'll probably explore this a little bit later on, but I think that's going to be pivotal to getting strategies like PBH to work.
Yeah, I agree.
So curious, just starting out, because we can come in here and talk all about the paper and the research and everything like that, but really I know that your background, there's a tremendous emotional weight that comes with your background and your entry into delivering care, and that was being in the North Tower during the World Trade Center attack on 9/11. So I'm just curious about your background, your inspiration to do this work, and what you believe is at stake if we continue letting mental health needs go unaddressed.
Sure. Yeah. So I knew I was going to change my career from being an equity analyst on Wall Street while I was sort of crouched under a table with the floor shaking and the ceiling coming down and feeling like, okay, if I get out of this, I'm going to do something different. And it took me a little while to figure out what that was, because first I got sort of knocked on my ass by the mental health ramifications of what I had been through. And so I really needed mental health systems of care. And I had the privilege to have enough money and enough connections that I could find somebody to work with and really get the recovery that I needed after that experience. But shortly after that, as part of sort of recovering and trying to reclaim a sense of agency and purpose, I trained as and worked as an EMT in Brooklyn. And it was in Brooklyn that I started to get really mad about our mental health systems of care. And it was because in our ambulance, we kept picking up the same 20 homeless schizophrenic guys, and we would pick them up once every 2 or 3 weeks, and we would bring them to the emergency department, and they would get, cleaned up, and they'd get 10 days of meds, and then they would go back on the street, and then they would go off their meds, and then we would get called again. And the finance mind that I had just couldn't stop adding up the numbers and thinking, this is really stupid. It's a terrible way to spend our money. Like, this is a terrible system. They're miserable. The hospitals don't want these patients. And, here we are in this, ambulance, just sort of carting them back and forth. We eventually put a little roulette wheel in the back of our ambulance with all the different hospitals, because we knew they'd all try to divert the patient to some other hospital. And so we just spin the roulette wheel, and wherever it landed, that's where we took them. And we wouldn't call ahead because we knew they were going to try and divert us to somewhere else. And that's not a system. That's a series of errors and a ton of waste. And that's what really got me fired up. And that's been my driving passion on good days, fury on the bad days, ever since.
Well, thank you for sharing it in that context, because being an EMT and seeing the same problem over and over again, it sounds like what you're focused on is being able to break that cycle that you were seeing over and over again.
Yeah, and we've been failing as a nation on that for 50 years, right? Our mental health burden has done nothing but grow. And we've built more and more systems to handle the acute crises. We've built out prisons that now house millions of people with mental health challenges. But we have not done much to get at the preventative end and start getting ahead of the problem. We are falling farther and farther behind.
Well, definitely want to get deeper in and discussing the upstream challenges, and also there's revolutionary work, there's also incremental work that we're focused on, I guess, in this conversation that can at least help the leaders who are listening to this drive towards some positive change.
Yeah.
So with that, one thing that I pulled from you, and even in this conversation, is just the importance of hands-on work, working collaboratively with patients. Can you talk about that hands-on perspective, but through the lens of precision behavioral health? And this is kind of to help lay a groundwork to define what PBH, precision behavioral health, actually is.
Yeah, I mean, if you think about the concepts of human-centered design, where really what human-centered design focuses on is, building things that are designed to be used by the humans who it's intended for, right? And you see a lot of this in development of medical devices, development of UX and other things, and was born out of, among other places, this great company, IDEO, that came up with these concepts. What human-centered design really focuses on is that, when you ground your design concepts in the needs of the person to whom that design is ultimately delivered, you stand a really good chance of building a thing that people will use. Mental health systems haven't been designed by patients or with patients' needs in mind nearly so much as they've been designed with the needs of clinicians, hospital systems, and payers in mind. And so our traditional models of psychotherapy, for example, are, a weekly session. That's not how most people learn, right? If you're trying to learn a new language, you don't go to class one day a week. You don't practice one day a week. And so we've built these systems that are convenient for clinicians because we set up our appointments, patients come see us, but they don't really align with learning styles or align with what patients really need. And so in terms of collaborating with patients, what I really try to stay focused on is this notion that when a patient has identified that they have a mental health need, and they've voiced it, say, to their PCP in primary care, they've already overcome fear of stigma. They've recognized that they have a challenge they can't handle on their own, right? And they've come in to try and do something about it. They've already overcome a bunch of barriers. And the first thing that happens to them is they run into yet another barrier, right? Which is trying to get access to something that can help them. Mm-hmm. And so from a patient-centered design perspective, one of the major focuses I have is every patient should get triaged into something that is appropriate for them within 72 hours of voicing that they have a problem. And we've actually studied this. We lose 50% of patients to follow-up after that 72-hour window. So this is a real factor. And so when we know that it takes patients 30 days or more to get connected with an appointment, and then we blame the patient for not showing up, it's not the patient, it's the system. We failed that patient. The patient came in having done a bunch of work. There was a sense of urgency around needing to solve their problem, and we told them to wait. So that's what I think about when I think about collaborating with patients, is really trying to take the mindset of somebody who's coming into a system, having the courage to voice their challenges, and then creating a system that meets them where they are.
The way that you frame that, especially talking about the blame for patients that don't follow up on things that perhaps they weren't able to, like things that might have required transportation or housing amenities that they don't have access to. It just makes me think that a lot of the time when we blame, we're giving up on trying to find an actual solution.
I'm glad you brought that up. I mean, showing up for an outpatient appointment at some location every week is a privilege, right? That means that you have flexible enough work, you have transportation, you have childcare coverage, right? These are all things that you cannot take for granted. But that's how our systems are, sort of foundationally based. We actually published a paper on our transition to all digital therapy that we made at the beginning of the pandemic, and we studied the impact, in particular, on our Medicaid patients. And what we found was lots of people were saying, "Oh my God, it's not going to work because technology." We actually reduced our no-show rate from north of 15% to under 3%. We do 8,000 additional visits a year because of this switch to digital, because digital meets the patient where they are. When the patient can see their therapist on their phone, they can do it on their lunch hour, or they can do it with their 1-year-old on their lap, and it overcomes a bunch of those systemic barriers that our system didn't acknowledge and was forced to acknowledge, right? We were forced to do it. We weren't doing it, right? There were echoes of doing it. The VA was trying to push it. Some places were trying to do it. But the pandemic pushed us into this space that we should have been in all along. Some of the next things I'm really interested in looking at is the notion of, why do you see somebody just once a week? If somebody's ready to do a lot of work, why wouldn't we see them every day for 3 weeks? do a whole bunch of work with somebody, get them to binge something, really learn that stuff concretely, and then move on.
And it would seem that that's part of the learning process of something like a PBH, a precision behavioral health, is understanding what's the dosage needed. And there's so much other stuff that I want to get into with you. Like we need to have a myth busting episode about like Medicaid and Medicare populations when it comes to technology. But we've got to, with the issue at hand, I want you to lead by example a little bit here. Just the story around why your team even developed this PBH approach, the challenges that you were addressing, and I guess a high level on some of the results that you're seeing early on.
Sure. So at Reliant, we have most of our patients are in full risk capitated payer contracts, which means that we're at risk for the total medical expense, right? And as part of that, we also get the claims data on all of their medical and behavioral claims. So we were able to use those to look at when we referred patients out for care in the insurance network, what proportion of patients that we referred for care got connected with care, and how quickly, because we know when we referred them, and then we can look at the claims data to see when they got their first visit. And so this really concretized the burning platform that we already knew about. Everybody talks about access to care, right? But we were able to really quantify it for our patients. And so what we learned was that for every 100 patients we referred out, 41 adults got connected with a visit with a therapist in 6 months.
Wow.
And for kids under 18, it was even worse. It's 27%.
And 6 months, that's a long window.
Well, the average time was 30 days.
Okay.
So not as bad.
I got it.
But 30 days is still a remarkably long time when you're suffering, right? It's like asking somebody with pain, telling them, don't worry, we will get you pain medication in 30 days. You just have to tolerate your pain for that long, right? That's unconscionable. But that's sort of how our systems are built in mental health. So that really was a big part of the burning platform. The other big part of the burning platform was that we have not actually moved the needle on mental health care effectiveness in more than 50 years. Right? Roughly 40% of patients who attend therapy in naturalistic systems get better. Right? Roughly 35 to 40% of patients who get on a medication get better. And we haven't changed those numbers in decades. And this created the premise for us that, well, that's not because necessarily therapy is broken or that therapists aren't that good. It's probably because we're sending a whole bunch of the wrong people into this big bucket of therapy, right? You need therapy, maybe, but maybe you need a dog, or maybe you need a coach or a trainer or something else. And this was the sort of the genesis of this idea that like we have to stop trying to be generalists with our solution, and we have to pick a whole bunch of very precisely targeted point solutions that address a certain proportion of our patients, and we have to be crisp about who gets that point solution. And so we started this 4 years ago by developing our DBT Center, which was the first all-virtual DBT center in the U.S. And we just got accredited by the Linehan Center. So we're now nationally accredited. And this was a point solution for a very specific kind of patient. And we were able to show that by applying that very expensive, high-intensity care to the right patient, there was a very compelling ROI. If we tried to generalize it, the ROI vanished. And I think this is a big challenge that we see is we try to take these solutions that might work for a small but meaningful percentage of patients and apply them across lots of patients. And it means that a lot of the patients that we send into that solution are the wrong ones. And that was really the sort of underlining burning platform for the precision adventure that we've been on for the last sort of 2 years.
Is there a way that we can have it play on repeat? If we try to generalize it, the ROI vanishes. Like that's a call to action for the importance of understanding those individual relationships and directing people to where they need to go. Can you talk about the high level results that you're seeing?
Yeah.
Or not just the results, but like a little bit about the process too of getting there.
Yeah. So there are a couple of key financial levers that you can pull in behavioral health to justify your reason to exist. Right. So in a fee-for-service world, you're obviously you're getting paid stuff to do your therapies, and to prescribe your medications, and that's your raison d'être. But if you're in a value-based world, what you care about is getting patients healthy, so that they stay out of the emergency department, out of the hospital, because then they cost less over time, right? And so the ROI is aligned with investing the right amount of intervention as early as possible so that you can enjoy the greatest amount of savings by preventing patients from hitting the emergency department, hitting that high-cost hospital care, right? There's another one that healthcare systems or most healthcare systems don't enjoy, but employers do, right? Which is that by keeping folks healthy, you keep them productive and happy at work, you keep them employed, right? That's another area that we don't tap into as a healthcare system, but it's another area of benefit. Then the other area is if you can bend the cost curve on the cost of treatment, right? So for most plans and sort of nationally, if you look at trends, the cost of psychotherapy in aggregate goes up by like 15% every year. We're spending more and more and more for psychotherapy, but we in the field of mental health haven't done anything to improve psychotherapy outcomes. Right? So we're paying more and more for a service that gets 4 in 10 patients improved. We can do better than that. And so another part of the return on investment is tweaking how many patients that you've referred into an intervention improve, because that increases the value proposition if your goal is getting patients recovered and healthy, right? So if instead of 4 out of 10, we move to 8 out of 10, right, we've dramatically increased the potential return for that intervention. Right? And so the idea about being crisp, about sending people into the right intervention, is that you can also tweak those numbers. You can juice those numbers by getting the right patient connected, and thereby getting your numbers from 40% upward closer to 80%.
So I'm putting myself in the shoes of someone who, first of all, had to spend a lot of time and effort overcoming a stigma enough to even say that there's a problem.
Yep.
And then struggled for a very long time to even be seen, or perhaps the types of things that were recommended to me didn't work, and I broke away after a session or two.
Yes.
So I'm just very curious about, with this system in place, what are you hearing from your patients?
So that's my greatest fear as a therapist and now as a systems builder, right, is of giving a patient the wrong treatment and leaving them with the message that, like, I can't get better. Right? I tried the thing that's supposed to work, and it didn't work for me. So I'm broken, and I can't be fixed, right? Because that is a terrible experience, and it leads to hopelessness and all sorts of other downstream consequences. And so, to try and solve for this, we need systems that are both able to use data, and I want to talk more about data because I think this is a place where we really need to up our game in mental health, that use data to sort of connect patients with things that are likely to be helpful for them, but also use data and feedback to notice when that person is not getting better. And instead of letting them quietly suffer and not get better, validating that by saying, you know what? The thing that we connected you up with, it's not working. We need to mix it up. We got to try something else. This isn't your fault. We just matched you with the wrong thing. Let's get you connected with something else. And so the way our precision behavioral health model is built at Reliant, the backbone of it is our sort of, state-of-the-art integrated behavioral health department. So we have an incredibly well-staffed integrated BH department that works right hand in hand with primary care. And we have real-time response rates with our integrated clinicians. And so if the moment that we notice that a patient's not on track, whether that's because they're filling out outcome measures that are showing us that they're not getting better or they're getting worse, or whether it's because they call in or their PCP lets us know, there are a variety of vectors, but it triggers outreach from one of our clinicians. And the goal really is to say, hey, we noticed this isn't working for you. Let's work on finding something else. Let's mix it up a bit and see if we can figure out what else we might recommend for you, rather than letting the patient feel blamed, feel like a failure in their treatment. We really want to own that the system didn't get them what they needed.
When you mentioned that one of your biggest fears is to send someone to something that doesn't work and then have them leave with the sense that they're broken and can't be fixed, I imagine that sense is shared among clinical teams, other clinical leaders as well. So I'm curious about the impact of bringing in precision behavioral health, if there's been perhaps any kind of impact on clinician burnout, or they're just what's been the clinician response to these systems in place?
So we are in the first weeks of our primary care pilot, where we have a clinical decision support tool that now sits in primary care and is helping them to identify. It basically tells them when a patient looks like they'd be appropriate for precision behavioral health, and then it actually guides them to the right recommendation and lets them talk through the recommendation with the patient. It's still too early for us to know what the impact of that is on them. So I can't speak to the PCP yet. Give me a couple months. But on our triage clinician side, so we triage, more than 10,000 patients, 15,000 patients a year. And on the triage clinician side, what it does is it empowers them with something that they know they can get patients engaged with immediately. One of the major burnout points that our integrated clinicians note with regard to triage is the pain of referring somebody out into a network knowing that they're unlikely to get connected with something, right? Because access is so hard to find. And they deal with that pain on a daily basis as they're triaging patients, talking with families, learning their stories, and then saying, I'm sorry, I don't have any space in-house to get you treatment. We have 40 FTE of therapists, but that's a drop. They're hilariously outgunned relative to the amount of need. Reliant has 350,000 patients in primary care. Right? And so that's where we've impacted burnout, is by giving our clinicians additional tools that they now apply to 30% of the patients that we triage. And now they can feel confident they got patients connected up with something they can start the next day. And they actually do a warm handoff to one of our digital care navigators, which is an important role to talk about, because these are folks who basically help the patient overcome any of the technology barriers to engaging with their treatment. And that allowed us to move from fewer than 30% of patients engaging with what we had recommended to north of 85% of patients engaging with the tool that we recommend for them.
That's a good point to bring up too, is the digital navigator. I think that, of course, people reading the paper will see that, but
Sure.
Just curious about the digital navigator and perhaps other means to help identify that precision part.
Yeah, I mean, our thesis was that if we build this into a primary care infrastructure, we ought to be able to do way better than EAP or payer in getting the patient bought into and engaged with a digital technology. And the key to really solving for that was we hired digital care navigators, where we hired charming people and trained them on everything else. And they all get to demo every single product that we have in our ecosystem, so they're experts on how to use it. Having those folks be able to get patients, registered, help, a 75-year-old grandmother learn how to recharge her virtual reality headset, talking them through the technology barriers has proven to be just a key part of the experience. The other great thing is they go from having a triage with a clinician to the next day or 2 days later having a visit with the digital care navigator. So they're getting a bunch of human hand-holding and connection as they're moving toward their digital experience. And it really helps the patients feel like they're not just being punted into something that's second best, but that we've put a ton of thought into this and tried to make this process as smooth as possible, which we have, right? That there's been so much thought and scrutiny on the digital tools that we use, more so than on therapy and therapists.
So I think that the conversation gives a sense for like the research and evidence that you seek to determine where intervention should go, and a little bit of on the operationalization. Sorry, can't even edit that. Can't even fix it. I can't say words. Sorry, y'all. But overall, there's a good perspective here, and it just makes me wonder about the people that are watching. They probably want to understand, like, communicating this with leadership, potentially launching and growing these types of initiatives. What are the types of things that you cleared with leadership, or how you got your peers on board with launching such a program?
Well, I will say that it is a privilege to be at Reliant, where I've been given a lot of room to take some risks and make some bets. And we've had a really excellent partnership with a division of Optum called Strategy and Innovation, who has really helped to fund and power a lot of this work. And so I feel very fortunate that I've had a bunch of people that I've been able to convince that this is the right way to be trying to, or one of the right ways to be trying to solve for the current mental health crisis. And, convincing them required a bunch of things, but I would say that the foundational piece was I had to convince everybody that we measured enough that we would be able to learn quickly if we were on the right track and doing the work, getting patients engaged, getting them recovered the way we hypothesized we would, or on the wrong track. And we really needed to take a fail-fast approach to build confidence in folks, because we had a lot of skeptics. We had a lot of people who said, no patient's going to want to do this. And we've clearly demonstrated that that's not the case. We had a lot of folks who said, it's also not going to work as a standalone treatment. We've clearly demonstrated that that's not the case either. We have a paper coming out on that. And so to convince them to take the risk of doing this, the burning platform's pretty bad, right? So there's a fair amount of buy-in there. And then that fail fast. And that required collecting the right data, right? This is where I think we have done ourselves a real disservice in mental health. We do not collect great data, and we don't do it systematically, and we resist it often. And what we have found, we use a system called Norse feedback, which is developed in Norway, and it measures sort of across 18 or 20 different scales. So it measures very robustly, far more robustly than like PHQ-9, GAD-7. And it allows us to look at meaningful differences between patients. This is where we get at the precision part of precision behavioral health. And by measuring so robustly, it allows us to identify profiles that represent really different people with different learning styles, different things, different needs. And then we can connect those learning styles and needs up with mechanisms of change and mechanisms of delivery across these different digital therapeutics. So some people would be really appropriate for virtual reality. Others really need a device that they can carry with them. Some people need something that's more socially enabled. Some people want really to just talk to peers. Other people need something that's wrapped around therapists. Like, there's so many different styles of learning. If we don't collect systematic and precise data, particularly data that's amenable to things like machine learning, we're just blind to our processes, and it makes it very difficult to become a learning health system. So by collecting the right data, I was able to convince major stakeholders that we were going to know really quickly whether we were on the right track or not. And we could create a series of failure milestones. At any time, we could have pulled the plug on the initiative, but we kept hitting our milestones. And so the key is not asking people to take things on faith. The key is collecting the right data to actually measure what you're doing and show it as quickly as possible.
Well, that's podcast number 3 idea that I want to do with you again, is getting deeper on the data element, because I think that would be very helpful to a lot of leaders. But it makes what we're getting to now and the relationship with leadership, it really segues into just I'm curious about we want the opportunity to learn along with you. We want to see what's happening. What do you anticipate, or how are you trying to grow this program going into next year?
Yeah, so the keys are, we've got about 2,000 patients through the program, and our overall sort of aggregate outcomes data are superb. Just really, really exciting. And I can't talk about it till the paper's out, but they're really good. So now our job is to move from these sort of aggregated results and continue to iterate on the specificity in the model. With 2,000 patients through the model, we can begin to see which tools did we send some of the wrong patients to, right? So we currently have 39 different patient subtypes. And we can see for different subtypes, well, we sent these subtypes into these two tools, but actually they did way better in this tool than they did in this one. And actually a bunch of patients that we referred into this tool got worse, and we had to triage them into something else. And that allows us to iteratively improve our recommendation algorithms, so that the system can learn from the past and get better and better at refining who goes where. So that's one key piece for 2023, 2024 is refining those algorithms, doing more of that machine learning work, letting computers do what they do best. Then another piece is identifying the gaps that we have in the digital technologies. Trauma, for example, is a big gap. We still really need to address that. And finding trauma therapy is nearly impossible. And so I'm really interested in exploring what digital tech can we use to try and address trauma. So that's another big one. And then the third big piece, there are a lot of pieces that we're continuing to prove out, right? The third big piece is proving that we can do it in primary care. That with a good recommender system, PCPs will use this much the same way as they prescribe a medication.
Well, I think the whole world should be looking forward to some of the results that you'll be publishing, especially I think that a challenge with a lot of digital health is there's a lot of competition where it need not be. If why would a digital health vendor review somebody as a competitor when they're a perfect fit for some population but not as good for the other?
I think what's really hard is I see a lot of very good point solutions out there that are good for maybe like 4%, 7% of patients that you're triaging. And alone, they can't solve big problems, right? And so the challenge for a lot of these really great digital startups is that there's a lot of pressure for them to expand their clinical horizon so that they can say, well, now we can address 40% of your patients. But what happens is, as they expand from that piece that they were founded on, that they're really good at and passionate about, their quality gets worse. Right? And so I think that there's a real challenge for digital tech and for systems designers around, you had said this early, there are some places that pay for dozens or hundreds of tools, but all the tools are underutilized. Right? This is where data plays a really important role, which is that, computers can stay mindful of all the tools you have in your ecosystem. And if the data helps you to inform who goes where, now you can build something that may apply to 70%, 80% of all of your patients. And it's made up of all these different point solutions. So you let the companies be great at what they're passionate about and what they're best at, and you let the systems build something that's applicable to a meaningful enough proportion of their patients that it's worth deploying.
So we have definitely talked about math. We talked about precision. Now we're going to talk about magic. The magic power that we bestow upon you through the power vested in the Meeting of the Minds podcast is the ability to change one single thing about healthcare and the way it's delivered. What would that be?
I go back to my finance brain. Mental health in America is really hard. Building systems of care is really challenging. And in part, it's because there are so many different and misaligned incentives. And so my fantasy would be to find ways of aligning all of those incentives in a unified model, where when we identified early that someone had a behavioral health need and treated it early, everybody, the patient, the clinician, the provider organization, the payer, right? Everyone benefited financially. Right? That would be the magic that I would do. Because right now, the way our models are built, it's really hard to prove return on investment in a compelling way.
Well, appreciate the thought there, and appreciate the work that you're doing absent of a magic wand. There's one thing about innovating, but like the sharing and showing it to others is extremely important and key to making that magic wand a reality. So for the folks watching that are slightly jealous of some of the work that you're hearing and interested in, following along with you, Sam, and keeping up with your work, what's the best way people can follow you on the internet?
I post lots of updates on LinkedIn. So when new papers come out, I try to keep that pretty well updated, and I'm always open to an email. There aren't enough of us, and so those of us who are trying to do this work need to band together and support one another. Send me a LinkedIn connection. I'm always happy to hear about more people who are fighting the good fight. It's hard enough to do alone. It's better if we can do it together.
That's so important. Fighting that fight can feel lonely too. So yeah, I think it's great to have you up here as an example, and other people who are of similar mind trying to guide down that path. Please reach out to Dr. Sam on LinkedIn. With that, everybody who's watched this, I really appreciate you for taking some time with me and Dr. Nordberg here. And there is a community of people that want to find the right strategies for innovation in healthcare. And a good example of that is the VP of Innovation over at Geisinger Health. If you're watching on YouTube, Emily Fry, her video with us should be appearing on screen, but she goes deep on operationalizing innovations for clinical workflow. With that, thank you so much for viewing, and thank you also behavioral health tech, Solome, Nicole, Danielle, and team. So wonderful. But thank you, and we'll see you next time.